Good morning. I would like to thank you very much for inviting me to give a short speech on this Congress. As was said, I am Tomasz Łoziński. I'm a gynecologist from Poland. This is place of my work, Pro Familia Hospital. This is the largest hospital in Podkarpackie region in southern Poland. We have 4,000 deliveries every year and 3,000 surgery procedures every year. We purchased a HIFU system in 2014 through an European Union research grant concerning improvement fertility among women with uterus fibroids. We have a 3 Tesla platform with table with cooling system. And this is a summary of our data. The number of consultative visits was 443, MR scans 332, qualified to HIFU 156 patients. It was 35%. Treatment 131, successful 93, unsuccessful 38. Interrupted treatments. Interrupted treatments were largely due to an adverse bowel location and pain during sonication and the patient's decision, such as no approval for filling bladder or rectum and lack of patience. Average time of our actions, patient's preparation 110 minutes. It is filling out the questionnaires, obtain a good position, filling out of bladder and rectum, sonication time, the table time, just 111 minutes, average time of whole treatment 220 minutes. And our results, necrosis 20% and below only in 8 treatments. 68 cases, it was 73% successful treatments with more than 50% of ablation. A feedback after 3 and 6 months indicated that the patient's symptoms such as bleeding and pain were significantly reduced. So, what is ahead of us? What can we do to improving HIFU therapy? A first aim is a decrease of limitations. A most common cause of our limitation and disqualification to HIFU were bad bowel position, adverse bowel position. So our idea is to try move and maneuvering uterus to front of the abdominal wall. My team with Technical University Wrocław is developing a manipulator to move uterus to front of the abdominal wall. If it is proves useful and successful, I hope it will be a mile step ahead, decreasing limitation patients. I think that will be necessary a mild anesthesia because these actions will be uncomfortable for patients, of course, but we have to remember and tell to our patients that the alternative is surgery procedure. A second our idea is to increase availability for gynecologists. A possibility of preliminary qualification by ultrasound imaging. I have to say that, unfortunately, most of my colleagues are unfamiliar with HIFU. They prefer surgery. Since I started HIFU therapy, number of patients to surgery treatment was increased by 25%. But we are only one center in Poland, so for us this is some kind of advertisement. The gynecologist absolutely should preliminary qualify patients to HIFU during regular examination. I hope that, I suppose that preliminary evaluation of vascularity in fibroid by ultrasound imaging is possible. We can measure a flow index, and we can measure a vascularity index and flow vascularity index, and preliminary evaluate a tumor to HIFU. We have big data in this topic and hope to publish this in short time. And third aim is improve collaboration between radiologists and gynecologists. I think that very important is more frequent referring for MR scans by the gynecologist patients with uterus fibroids. This is very important. And the fourth aim, last point is finding a medicine to increase sensitivity tissue for ultrasound beam. Dr. Kim said yesterday about the GnRH. We are going to do research with oxytocin, misoprostol, medroxyprogesterone. These medicines are used in obstetrics to stop the bleeding after delivery. It seems that it can be useful also in HIFU, but I cannot tell this certainly yet. Thank you for attention.